Hello, thank you for listening to my presentation today. This presentation today is called A Crash Course in Fertility by me, Gabby Johnson, and I am an FFP medical student currently undertaking a special study module in subfertility and what that entails. So this is a crash course into what I've learned over the course of this special study module. So what am I going to cover in this presentation? I'm going to cover how we approach a couple in the fertility clinic, some important questions that we may ask the couple to get some more information and form our treatment plan, some key investigations that we may wish to order, and the reasons for this will become clearer as the presentation goes on. And finally, some treatments in fertility. This is not an exhaustive list, but for the purpose of this presentation, I'm going to cover IVF, IUI, and ovulation induction. So how do we approach a couple who have been unable to conceive? So a couple would be defined as a couple that have been trying to conceive for over a year whilst having unprotected regular intercourse, and this itself is defined by 3 or more times a week, and they can then be referred to as the fertility clinic by their GP. If everything is perfect and there is no reason to suggest infertility with a couple, they will have a 15 to 20% chance of natural conception each cycle. And this is why we ask couples to wait for a year, so that we can make sure that they have done enough cycles to show that it's worth investigations taking place and potentially helping the couple to conceive. But what do we actually do when we see them in our clinic? So let's look at an example couple. So 32-year-old Mrs. Scott presents to the clinic with her 55-year-old partner, Mr. Scott, who is presented to the fertility clinic with the history of 1 year of subfertility. So we might want to ask them some quite important key questions. There may be many more questions that we wish to ask, but these are some of them. So how regularly do they have intercourse? This is very useful background context to see how often they're having intercourse, and this would show us the chances that they are conceiving, as it may be that they need to have more intercourse within that month, but this may not be the reason also. Does Mrs. Scott have regular periods? There's many reasons why a woman may have irregular periods. Some of these reasons may be polycystic ovarian syndrome, thyroid dysfunction, and this will show us potentially how often Mrs. Scott is ovulating, if at all, and therefore how many cycles there may be chance of fertilisation of the egg. Have either Mr. and Mrs. Scott been able to conceive before or have children? This gives us some quite important insight, but also tells us if they may be eligible for certain NHS funding for some of the treatments that may be offered, such as IVF. So it's important we know this so that we can give them the correct advice and treatment options. Has Mrs. Scott had any previous sexual infections or surgery? This may cause damage to her fallopian tubes, and an example of this may be chlamydia, and it's an important thing that we test all ladies for when they present to us in the clinic. And also abdominal or gynecological or ovarian surgery may cause some adhesions, and this may be impacting on her fertility. Is Mrs. Scott up to date with her smears? This is important to understand her gynecological health, but also cervical cancer may cause some problems that cause her infertility and difficulty in conceiving. Do either of them smoke or drink alcohol? This may reduce their chances of conception, but also if Mrs. Scott was to become pregnant, it is important that she is not smoking or drinking alcohol at this time. And what is Mrs. Scott's BMI? This may impact on how regular her cycles are, but also her treatment options, as this will become clearer throughout the presentation, as some of the criteria do involve the lady's BMI and also the male's BMI in the case of surgical sperm retrieval. So investigations, regardless of those answers that Mr. and Mrs. Scott give us, we need to do some key investigations. When assessing the reason for subfertility, there are 4 key areas. The eggs themselves, so hormonal tests may include FSH, LH, progesterone, and AMH. So we want to know, is Mrs. Scott ovulating? And the progesterone on day 21 or in the mid-luteal phase may give us an indication of if she is ovulating. FSH and LH may give us an indication of if she is stimulating a mature egg, and this is then being released in ovulation. And AMH is looking at her egg reserves, and this may impact dosages and treatment plans for things such as IVF. Number 2 is the uterus. So we do a pelvic ultrasound. We want to look at the shape of the uterus. Is there any adhesions, or is there any fibroids that may be in an area that may be impacting on her fertility? Number 3 is the fallopian tubes. So we do a HSG test, which is a dye test to look at the fallopian tubes to see if they are patent and if there's any blockages at all or any damage to the tubes that can be caused by infections as discussed. And fourth thing is the sperm. So we do a seminal analysis. So we want to know the volume. We also want to know the sperm count and also the shape of each sperm, the morphology, and the motility of the sperm, which includes the direction it's traveling in and also at what speed. So what if these are all normal? So 40% of couples that we see in infertility clinic will have unexplained infertility, meaning all the tests have shown that things are normal. However, there may be an underlying reason that we are not aware of or that we cannot see, which is causing the infertility. And in this situation, we may offer some treatments to the couple, such as IVF or IUI, or alternatively, there is still a chance at natural conception if all the tests are normal. So we can advise that they can keep trying naturally if they would prefer to do this and then come for treatment later. So what are some of these things that we're talking about, such as IVF or IUI? IVF, so in vitro fertilization, there's some really important criterion that changes area to area that's associated with IVF. For the Derbyshire area specifically, in order to have NHS funding for IVF as a couple, neither partner would be able to have any children, and the lady must have a BMI of less than 30, as this will impact the chances of success. If all the criteria are met and there is a longer list than I have spoken about, then in Derbyshire specifically, the couple could have one cycle of IVF. This will include the egg collection, embryo transfer in a fresh cycle, and also if any embryos have been frozen, this would all be included in one cycle. So more about IVF. In one cycle of IVF, there is a 45% to 50% chance of success cycle. If the couple was ineligible or would rather go privately, the cost of self-funded IVF is £7,000 per cycle and potentially a subsequent £2,500 to £3,000, depending on the area for frozen embryo transfers. 40% of couples will have enough top quality embryos to freeze these and continue with their cycle if their fresh cycle is unsuccessful. But these embryos must be of top quality, meaning they have a success rate that is worth doing this for, and also they would survive the freezing process. So the concept of IVF simplified. First of all, the lady would take progesterone for 10 days. This is to induce a bleed. On day 2 of this bleed, she would then commence on either FSH alone or a combination of FSH and LH injections to stimulate the production of multiple eggs. These eggs are then collected in egg collection. These eggs are then fertilised with fresh sperm or by donor sperm or frozen sperm too, and 70% of these eggs will fertilise. This can be done in 2 different methods. This can be conventional IVF, where multiple sperm are put around the egg, giving the chance of natural selection, or by a technique called ICSI, where a single sperm, the fast-moving motile sperm are picked, and one sperm is fertilised and injected into the egg. And this is usually done if there's some problems in the seminal analysis. After this, we wait for the embryos to get to day 5 stage, called blastocysts, before choosing the best embryo and doing the embryo transfer procedure. There are some risks associated with IVF. One of these is ovarian hyperstimulation syndrome, where we have overstimulated the ovaries, and this can cause some symptoms such as pain, but also it does mean that we may have to freeze the eggs or the embryos and continue with the cycle later once we've allowed the body to readjust to this. The procedure itself may not work, so this could include no eggs being retrieved, eggs not fertilising, and embryos not implanting and leading to a pregnancy. IUI is a different treatment that I have mentioned. This is not funded by the NHS in the Derbyshire region, but couples may choose IUI and pay £1,000 a cycle, but with this the success rates are lower, and this is 12 to 15% a cycle. So it's sometimes known as artificial insemination, but it is the same procedure, and this is a treatment where we choose better quality sperm, and we put this directly into the uterus so that we make sure the sperm are closer in the environment and better chance of fertilisation leading to a pregnancy. So some different scenarios. What if Mr. Scott had a problem with his seminal analysis? We've touched on this briefly, but if he was shown to have azoospermia, so a sperm count of 0, there are some important additional tests that would need to be carried out. One of these is a confirmatory semen analysis. So we would like to wait 3 months for this, but we would like to see this again on a second sample. If this was still the case, we would then proceed with a cystic fibrosis screening, a karyotype to see if there's a chromosomal abnormality, a physical examination, and also plasma FSH, LH, and testosterone concentrations, as even if there's no sperm seen in the analysis, there may still be sperm production in the testes, and these hormonal levels will give us an indication if this is the case, and the couple's chances of having a procedure such as a surgical sperm retrieval and the success of this occurring for them. So what if Mrs. Scott had irregular cycles? As touched on previously, we would have to do some thyroid function tests, but we could also do measurements such as the plasma testosterone concentration, as in PCOS there is a hormonal imbalance and raised levels of testosterone, but this would have to be coupled with some symptoms, and these may include abnormal hair growth and insulin resistance, so obesity or weight gain. And it's important that we not only see evidence of PCOS on blood tests and symptoms, but also the presence of polycystic ovaries may be seen, but this is not always the case in PCOS, and a diagnosis may go ahead without this. So what could we do for Mrs. Scott if she has PCOS and irregular ovulation? There's a treatment called ovulation induction. It's important again to note there is a criterion for this, and her BMI would have to be less than 35. Examples of these medications are letrozole and clomiphene, and it's really current at the moment as there is a Loki trial happening. Many studies have already looked at letrozole versus clomiphene and which one is more successful. But this new trial looks at not only letrozole and clomiphene, but the addition or non-addition of metformin, as this is seen to be a useful medication in PCOS. So that's something that's current at the moment that's going on. But letrozole is to help women who are not ovulating regularly, such as women in PCOS, to help the body to stimulate mature eggs and the release of the egg. And it's just encouraging this process. Clomiphene itself is a weak estrogen-like hormone that acts on the pituitary gland and also the ovary to increase levels of FSH and LH. We like to scan ladies on day 11 of their cycle just to make sure that this treatment is working for them and ovulation is occurring, as no more than 12 cycles are recommended in a lifetime due to the risks of ovarian cysts and cancer risks. So it's important that we know the treatment is working for them, and we could offer other treatments or increase the dosage if relevant. So in this presentation, I have covered an example couple that we may face in the fertility clinic, important questions we would ask the couple, key investigations without ordering unnecessary investigations, and common treatment pathways that may be used in fertility. And I thank you ever so much for listening, and I would be very appreciative of any questions and anything you would like to ask me. So thank you very much again.